Good evening, dear students. We were discussing about the liver tumors. In the previous class, we studied few points about the hepatocellular carcinoma. Today we will finish them and then we will go to the other tumors of the liver also. We are discussing about the investigations of the liver cell hepatocellular carcinoma. Alpha fetoprotein. It is the normal constant of fetus of 6 months of age and disappears in few weeks after birth. It is called tumor marker for hepatoma. It is useful for screening patients of cirrhosis for hepatoma and for follow-up of the case. So because cirrhotic patients, they may go into hepatocellular carcinoma, so they can be screened by doing regularly once in 6 months the AFP, so you can identify the hepatocellular carcinoma in these patients. Ultrasound scan, CT scan, they will show you the hypoechoic or hyperechoic masses. Already I told you about the hypo and hyperechoic masses. CT scan is mainly performed to exclude hemangioma. Out of hemangioma and hepatocellular carcinoma, which is more common in the liver? Yes, true. That is hemangioma is more common. So once you find the mass by ultrasound scan, what you have to do is you must do CT scan. The purpose of CT scan is to exclude the hemangioma. Once you exclude hemangioma, then you go for liver biopsy. Either percutaneous laparoscopy or peroperative under guidance. That means under CT guidance, you have to do the biopsy. Sometimes you may have to do laparoscopy and then you have to take a biopsy from the liver mass. Arteriography has to be done if you plan to do segmental resection. So to know about the celiac and hepatic artery architecture inside the liver and which part of the hepatic artery branch supplies the tumor, to know that you have to do the arteriography. So this is a tumor of the liver, hepatocellular carcinoma. You can see the irregular border. That means it is a type of infiltrating type. We have seen there are three types are there: the expanding type, the infiltrating type, and the diffuse type. So this is the infiltrating type. It carries a bad prognosis. Then a localized variety. That means it just looks like a benign tumor. Differential diagnosis of mass in the liver. So whenever you see a solid mass in the liver, clinically we will make a diagnosis of hepatocellular carcinoma, but you have to exclude, you have the differential diagnosis of solid mass in the liver. It may be solitary liver mass. It can be due to amoebic abscess. Usually amoebic abscess will be subacute form. That means the abscess will be tender on palpation. But sometimes the abscess becomes chronic, especially the patient's immunity is better, then it becomes chronic. In that case, there will be thick fibrotic wall around the abscess. So then the abscess becomes firm or hard in consistency. So then it mimics a hepatocellular carcinoma. Hydatid cyst, because it has fluid, it should be usually soft in consistency. But hydatid cyst will not be soft in consistency because the fluid is under tension. So it feels like, so any cyst with fluid under tension feels like a solid mass. Then secondary is liver, renal mass, carcinoma stomach. So clinically, when you find a solitary mass from the liver, you have to think of these conditions: amoebic abscess, hydatid cyst liver, and secondary in the liver. Sometimes liver secondaries may be also solitary. Example from the colon. Carcinoma of the colon, when metastasis to liver, sometimes it manifests as a solitary secondary. Then right renal mass has to be differentiated from the liver. Then carcinoma of the stomach has to be differentiated from the liver mass, that is left lobe of the liver mass. Management, surgery. Only 20 to 40% of cases are amenable to surgery. Indications for surgery: mass localized to one lobe, not associated with cirrhosis, good general condition of the patient. Because it is a major operation, the patient general condition should be good to withstand the surgical as well as anesthetic risks. Contraindications for surgery: extrahepatic metastasis, multiple and bilobar tumors, involvement of the main bile duct, tumor thrombus in main portal vein or inferior vena cava, the surgery is hemihepatectomy. That means one half of the liver is removed. So we know the Cantley's plane. So basing on the Cantley's plane, you do either right or left hemihepatectomy. So you can see this is the inferior vena cava and here is the gallbladder. So the cystocaval plane or Cantley's plane is the plane which cuts through the surgical lobes of the liver. So here you can see the left lobe is preserved, the right lobar hepatectomy was done. In this case, the left hemihepatectomy was performed. Liver transplantation. It is indicated in patients with cirrhosis and tumor less than 5 centimeters in diameter or 3 nodules with each of them less than 3 centimeters with no evidence of vascular invasion and metastasis. So usually the hepatitis B and hepatitis C patients, they progress from cirrhosis to carcinoma of the liver. So when there is associated cirrhosis, then you can plan to do liver transplantation provided the tumor size is less than 5 centimeters. If there are 3 nodules less than 3 centimeters in diameter, then also you can go for liver transplantation. The other form of surgery is the segmentectomy. That means one segment of the liver bearing the tumor can be removed with clearance of 2 centimeters around the tumor margin. It is done in patients with associated cirrhosis because of high incidence of liver failure in these patients if hemihepatectomy is done. So cirrhotic patients, they cannot tolerate removal of half of the liver. So in such patients who cannot afford to have liver transplantation, then you can go for segmentectomy. So the segment bearing the tumor mass can be removed with clearance of 2 centimeters margin around the tumor. Chemotherapy. Systemic or selective hepatic perfusion. That means you have to perfuse the hepatic artery under fluoroscopic control. Just we have seen the Seldinger's technique. So with the same technique, a catheter is passed into the hepatic artery and the chemotherapy drugs are selectively injected into the tumor bearing segment of the liver. So by that you can give high doses of the chemotherapeutic agents so that it will have more effect on the tumor. So you can give 5-FU, mitomycin C, vincristine. The other measures being, these are all the palliative measures, ligation of branch of hepatic artery by therapeutic embolization, open surgery and hepatic artery ligation when facilities for therapeutic embolization are not available. So whenever the patient is having an inoperable tumor, but patient is having a lot of pain or hemorrhage for the tumor, then you have to go for these things. So this is the last resort, but usually these patients will fare very badly even after surgery. Other palliative methods, RF or microwave ablation, intralesional ethanol injection, cryosurgery. That means, you know, the microwave that is being commonly used in the kitchen. So in the same way, there will be microwave generators will be there. So these microwave generators are used to radiate the liver tumors. So with that, the liver tumor gets cooked away and tumor gets necrosed. So this is only done as palliation in patients with inoperable liver tumors who complains of severe pain as well as bleeding. So in those patients, you injection of ethanol or absolute alcohol into the tumor directly or cryosurgery. Of course, these methods are not being utilized nowadays because they give a lot of complications and survival benefit is not there for these cases. There is one more rare tumor of the liver that is called hepatoblastoma. It is the most common malignant tumor of the liver in children. Prognosis is poor in these patients. Secondary liver. Secondary liver are the commonest malignant tumors of the liver. The source of the primary. It can be carcinoma, it can be sarcoma, it can be carcinoid, or it can be melanoma. Or it can be lymphoma. So the primaries can be from any one of these tumors. So all types of neoplastic, malignant neoplastic lesions can have secondaries in the liver. Secondaries liver is one of the most important topic because in the clinicals, liver cases means you will get usually solitary masses, that is hydatid cysts, or chronic amoebic abscess, or hepatocellular carcinoma. Hepatocellular carcinomas, they are not so common for in our country. That's why we may not be able to see a case in our country here. So, but whenever a solid mass is given to you, you have to discuss about hepatocellular carcinoma. Then the commonly given case is multiple secondaries in the liver. So secondaries in the liver, whenever the case comes to you, you have to have a good discussion about secondaries because secondaries liver means the examiner can touch you anywhere in the body. Where the primary can be anywhere in the body and that can metastasize to the liver. So the discussion will be very wide and far. The sources of the primary can be from a carcinomatous mass, a carcinoid lesion, melanoma, from a sarcomatous lesion, from a lymphomatous lesion. Mode of presentation, multiple nodules with generalized irregular enlargement of the liver. Sometimes the nodules may be as big as this in this case, or sometimes it may be just tiny nodules like this. So the whole liver will be studded with multiple nodules. This is the commonest mode of presentation, and the nodules are classically described as umbilicated. Umbilicated means in the center of the mass you will find necrosis. So because of the necrosis, when you carefully examine the mass, in the center you will find small depression. So the depression feels something like the umbilicus. That is what is called umbilication of the masses. But I have never found this umbilication in any secondaries in the liver. But in the books it is described that umbilication is a classical sign of secondaries of the liver. So the commonest mode of presentation is as multiple nodules in the liver. The second mode of presentation is as a massive hepatomegaly. That means diffuse hard enlargement of the liver. This is rare. The third type of presentation is as a solitary mass, especially from carcinoma of the colon. The primary is in the carcinoma of the colon. It can metastasize to the liver and form a solitary mass. Carcinoid secondaries, they need a special mention. They are nodular, diffuse enlargement of liver will be present. It is associated with carcinoid syndrome. This carcinoid syndrome is again one of the most important topic and is frequently asked in the theory examination. What is carcinoid syndrome? Do you have any idea? Carcinoid syndrome. Do you have any idea about this? What is carcinoid? What is the other name for carcinoid? Do you know it? What is the other name for carcinoid? In one of the previous examination, I think about 2 or 3 years before, in the examination, that particular name was given, not as carcinoid syndrome or not as a carcinoid tumor. Hope I am audible. First of all, tell me, am I audible or not? Ah, very good. Ah, wonderful. It is called neuroendocrine tumor. Very good. Then what is carcinoid syndrome? So if any patient who is having this tumor presents with flushing of face, diarrhea, bronchospasm with wheeze, so then we call this as carcinoid syndrome. What the cause of this syndrome? Release of 5-hydroxytryptamine, histamine, and kinins by the secondaries directly into the systemic blood. This carcinoid tumor arises from a different cell. They arise from the ileum cecum appendix most commonly, sometimes from the bronchus also. They release these hormones, the 5-hydroxytryptamine, histamine, and kinins. They all produce the vasodilatory phenomena, so that's why they cause flushing of the face. And the kinins, they can cause diarrhea. 5-hydroxytryptamine cause bronchospasm and dyspnea. Because they are produced from the ileal or appendicular region, all these hormones or chemicals, they are transported to the liver normally. The tumor in the ileum or appendix, the patient do not get the carcinoid syndrome. But when this tumor becomes malignant and this malignant carcinoid metastasizes to the liver and causes multiple deposits in the liver, then these secondaries, they are functional. Functional means they also secrete these chemicals. So then these chemicals are directly poured into the systemic circulation. That is why carcinoid syndrome is present only in liver secondaries. If the tumor is there in the ileum or appendix confined there without any metastasis, then they do not have the syndrome. So presence of syndrome always indicate that the patients have secondaries in the liver. Can you tell me an exception for this rule? That means without secondaries also, the carcinoids in some other places can produce carcinoid syndrome. I hope you got the answer. Oh no, it's not the appendix. Carcinoids present in some sites can produce carcinoid syndrome even without having metastasis to the liver. Yes, bronchus. As why? Why so? Why a bronchial carcinoid produces carcinoid syndrome and why appendicular carcinoid cannot produce syndrome unless it metastases to the liver? Why? Is there a reason? Why a bronchial carcinoid produces syndrome? Yes, good. The bronchial carcinoid secretions directly into the systemic circulation. That is why the patient gets this syndrome. In case of ileal carcinoid and appendicular carcinoid, all their secretions go into portal vein, so they are not communicating with the systemic circulation. So portal circulation will go into the liver. Liver detoxifies them. That is why the patients do not manifest with this syndrome. Primary may be in the appendix, ileum, or bronchus. Metabolism of these chemicals occur in the liver. Hence, carcinoids arising from gut do not produce carcinoid syndrome. But carcinoids from liver secretes these amines into systemic circulation and produce carcinoid syndrome. Clinical features of secondary liver. There will be hepatomegaly, diffuse hepatomegaly with multiple nodules. There may be solitary mass in the upper abdomen, either from the right or left lobes of the liver. Diffuse infiltrate type presenting as a cirrhotic liver, it is a very rare. There may be associated jaundice. So this is one of the frequently given cases in the examination. Secondary liver with jaundice. Then common question you get from the examiner is what the cause for jaundice in secondary liver? Can you tell me why jaundice occurs in secondary liver? Why jaundice occurs in secondary liver? Obstruction of ducts. Yes, you are right. It is obstruction of bile ducts in the porta hepatis. When a large mass of secondaries are there, so they can cause obstruction and produce secondaries. In the diffuse infiltrative type, the bile ducts are completely infiltrated, so that can produce the jaundice. There may be ascites, secondary liver with ascites. How ascites is produced in secondary liver? Tell me. Portal hypotension, no, it is incorrect. Very good. Second is in the peritoneum. Associated secondary deposits in the peritoneum can cause ascites. Number 2, associated hypoalbuminemia due to malnutrition. The parietal wall deposits will not be there. It will be peritoneum deposits. Hypoalbuminemia deficiency. Yes, that is good. So it is ascites due to associated implantation of malignant cells for the peritoneum, associated cachexia and hypoalbuminemia. And in secondary liver, there may be associated features of primary disease. That means carcinoma stomach, carcinoma colon. They have their presentation features. Depending upon the manifestation of the primary and secondary, it is classified as follows. That means a patient with secondary liver. So when he manifests with secondaries, that means whether the primary malignancy and secondaries manifest together, or primary manifests before, after removal of the primary, secondary manifests, or patient comes to you one with secondaries with unknown primary. So there are 3 types of clinical presentation of liver secondaries. Yes, all are possible. So there are 3 types of presentation. So depending upon the manifestations of the primary and secondary liver disease, these manifestations can be classified into synchronous metastasis. The secondaries in the liver and primary disease manifest simultaneously. So in the clinicals, when you examine, you will find a mass in the stomach and you find diffuse liver enlargement with multiple nodules. So that means primary and secondary both are seen. That means then we call it as synchronous metastasis. Precocious metastasis. There is occult primary. Primary is not evident, but secondary is manifest. So sometimes the primary will be very small. You cannot detect it. But patient comes to you with secondaries in the liver. The primary may be from the stomach, colon, breast, peripherally situated bronchogenic carcinoma, or melanoma, particularly in the anal canal. So from these tumors, sometimes the primary do not have the symptoms. But patient comes to you with mass in the upper abdomen, and when you examine, you will find multiple nodular liver. So when you thoroughly examine, you may not find any lesion in the stomach, in the abdomen, or anywhere else. But the growth in the stomach may be very small. Similarly, colon, the breast, bronchogenic carcinoma, melanoma. So these are the places which you must always think of in a case of occult primary with secondaries in the liver. This is called the precocious metastasis. Metachronous metastasis. Secondaries in the liver manifest after the treatment of the primary lesion. For example, a patient with carcinoma breast comes to you. You do all the examinations and investigations. You find a lesion confined to the breast only. Then you plan to do surgery and then you do the surgery. 1 year later, patient will come to you with mass in the right hypochondrial region, and when you scan it, you will find multiple nodules in the liver. So then it is called as the metachronous metastasis. So all 3 types of manifestations patients can have. Investigations for secondary liver, alkaline phosphatase estimation, usually it will be elevated. Ultrasound scan will show you multiple hypoechoic masses in the liver. CT scan will be helpful. Histopathological confirmation is done by guided liver biopsy. Tumor has to be done by relevant investigations like X-ray cyst, PET scan, upper GI endoscopy, colonoscopy, mammogram, etc. So you have to first do a thorough examination of the whole of the body, and when you find a mass and an ulcer, you should do the investigations necessary to find the diagnosis in the primary. So you can see multiple secondaries in the liver. They can be large size and some of them are very small in size. So they are diffusely placed, arranged. Sometimes there may be a solitary secondary. One large mass will be there in one lobe of the liver. So this usually is seen in case of carcinoma of the colon. Management of secondaries. So whenever secondary is present, what is the stage of the disease? Anywhere in the body. When secondaries in the liver are present, what is the stage of the disease? No, it is not T4, it is stage 4. Or you can call it as M plus. T4 means the tumor size. TNM, metastasis in liver, means M plus. It is not T4. So when M plus is there for any tumor, we classify it as stage 4 disease. So stage 4 disease means it is almost inoperable and patient survival will be very short. So usually the treatment will be chemotherapy. Surgery is indicated in certain cases. When it is a localized mass and primary is resectable, as in colon cancer. The colon cancer, sometimes what happens is it is locally resectable. That means tumor is mobile. It has not infiltrated the surrounding structures. But it has metastasized to the liver. And usually colon cancer metastasizes as a solitary mass in the liver. So you do a CT scan and then examine the liver, you will find only a single mass in the liver. Colon also is having a growth. Then what you do is you do the hemicolectomy operation, and along with that one you do right or left hemihepatectomy. That means the solitary mass is removed. So it has been studied that when you do like that, the patient survival will be just like the usual colon cancers without liver metastasis. So though it is an inoperable or advanced stage, but in colon cancer, when it is solitary, when you resect the liver, then patient survival will be very good. So it is always recommended. Right, simultaneously, both of them appear simultaneously. That means if there is synchronous metastasis of the liver secondary and colon cancer. Segmental excision or hemihepatectomy, then metastatectomy. The other procedure is called the metastasectomy. Yes, colon cancer and solitary liver secondary both are removed in this similar. So the other procedures are segmental excision. That means when you do only confined to only one segment, you can remove that particular segment. If it is a large secondary occupying 2 or 3 segments, then you can do hemihepatectomy. Metastasectomy, that means removal of the metastasis. Removal of isolated nodules is performed if the masses are small and 1 to 3 in number. The aim of doing this surgery is to reduce the bulk of the tumor for better action of chemotherapy. This is an example of solitary liver secondary from colon cancer. So you can see it here in the computed tomography as well as in PET scan. You find the mass here in the liver. And the patient underwent hemihepatectomy, right? Hemihepatectomy along with hemicolectomy. 2 years later, when again a CT scan was done, you find there is no evidence of any mass in the lobe. And actually, the right lobe, which is removed here, half of the right lobe was removed. When you take a CT scan after 2 years, you can see the growth of the right lobe here. That means the left lobe has taken the place of the right lobe. So there is compensatory hyperplasia of the lobe of the liver. So looking as if it is a normal shaped liver. So here is the spleen and this is the liver. No, this was a colorectal cancer. It's from rectal cancer, not from the ascending colon. Rectal cancer. Rectal cancer and colon cancer, they behave alike. If it is a T2 lesion or T1 lesion or T3 lesion with M plus, that means solitary metastasis in the liver. So without infiltrating the wall of the colon into surroundings, within the wall, then you can do this resection. Why it occurs only in colon cancer like the solitary secondary? Of course, the reason is not known. It is not explained. So what you have to know is secondaries in the liver means it is a late stage. But for colon cancer, it is not a late stage. Still, you can do hemihepatectomy. So colon cancer is one of the commonly seen cancers in our country. So in the examination also, you may find a patient with right iliac fossa mass or left iliac fossa mass or rectal cancer. So the same fellow may be having secondaries in the liver, either on clinical examination or on CT examination later. So because CT scan shows a secondary in the liver, normally what we say, it is stage 4 disease. Stage 4 disease means we give only palliative treatment. We don't go for a curative resection. This is normal. For example, breast cancer is there, a lump in the breast with secondaries in the liver. What we give? We do only palliative treatment. Stomach cancer, we do palliative treatment. But in colon cancer, if though one secondary is there in the liver, it is not considered as an advanced disease. You do a radical resection for the colon cancer and do hemihepatectomy. The patient survival will be as normal as a patient with T1, T2 lesion only. That means stage 1, stage 2 disease. So that is the difference between the colon cancer management and other secondaries in the liver. Prognosis, secondaries means worse. So once secondaries has developed in the liver means the prognosis of the patient will be usually in course of months only. Cholangiocarcinoma, that can occur in the liver. Inside the liver, the bile ducts are there. So some of these ducts can be affected with cholangiocarcinoma. So already we have discussed. Did we discuss? No. Okay. We have discussed only about the bile duct stones. So today, if time permits, we will discuss about the cholangiocarcinoma after completing the liver topic. Then benign tumors of the liver. Hepatic adenoma, Hepatic adenoma incidence, it occurs in age of 25 to 50 years. Females are exclusively affected in this condition. Etiology, concept of pills. Pathology, solitary usually. They are very vascular tumors. Clinical features, usually they are discovered incidentally in ultrasound scanning. Sometimes they may present with pain in the right hypochondric region, or there may be spontaneous bleeding from this adenoma. Just like hepatocellular carcinoma, hepatic adenoma also can manifest with spontaneous hemorrhages. Treatment, excision if it is more than 5 centimeters in diameter. Hemangioma of the liver, it is the most common lesion of the liver. It may be multiple, it may be very large, and then it's called a giant hemangioma. It usually manifests without any symptoms, so incidentally discovered on ultrasound scan. Whenever you find on ultrasound scan, how do you make it out on ultrasound scan? Tell me. On ultrasound scan, what do you see if it is hemangioma? On ultrasound scan, I'm not talking about ultrasound scan, you just see it as a solid mass. That means a hypoechoic lesion. Because hemangioma contains a lot of blood in its vascular spaces. So it presents like a hypoechoic mass. So if any hypoechoic mass in the liver can be a tumor, a carcinoma of the liver, or secondary in the liver. That's why, first of all, whenever you see hypoechoic mass, you must consider it to be neoplastic. So whenever you doubt neoplasm, what usually you do? You go for a biopsy. But in the liver, you should not do that biopsy because hypoechoic masses in the liver, when you see, most common hypoechoic mass in the liver is hemangioma, not hepatocellular carcinoma. So if you put a needle there, then there will be profuse bleeding. So once you find hypoechoic mass on ultrasound scan, the next thing you have to do is confirm it by doing a CE-CT scan, contrast enhanced CT scan. So when you give contrast intravenously and take a CT scan before giving contrast, then what will happen? Hemangioma, because it has a lot of vascular spaces. So all this contrast will pool there. That's why it gives a lot of enhancement. This enhancement doesn't occur immediately. There will be slow contrast enhancement. So whenever there is contrast enhancement is there, that means that it is a vascular lesion. In case of hepatoma, which is also vascular, it can also have contrast enhancement. But that contrast enhancement is immediate. As you are giving the contrast itself, you will see enhancement in the hepatoma. But in hemangioma, it is seen slowly. Hemangioma is a vascular anomaly. So is it arterial anomaly, venous anomaly, or capillary anomaly? What is it? Hemangioma, is it an arterial anomaly, venous anomaly, or capillary anomaly? Hemangiomas can be of any three types: arterial hemangioma, venous hemangioma, and capillary hemangioma. What is it? So the most common variety is the capillary hemangioma. Arterial hemangiomas of the liver cannot occur. Venous hemangioma sometimes may be there mixed with capillary hemangioma. So most of the malformations are because of capillary hemangiomas. So because they are capillary hemangiomas, the contrast which is given into the intravenous circulation will not come into the hemangioma immediately. If it is arterial related, as you are giving into the vein there, so blood circulation time is about 16 seconds. So within 10 to 15 seconds, you will find the contrast seen in the mass in case of hepatoma. In case of hemangioma, the arteries, the contrast should leave the arteries, it should go into the arterioles, then it should fill the capillaries. Then you will find the enhancement. So it is a slow contrast enhancement. So by that way, you will differentiate the enhancement of the hepatocellular carcinoma and enhancement produced by hemangioma. So once there is slow contrast enhancement, you don't go for any biopsy. If there is rapid contrast enhancement, that means it is a tumor, then you do a guided biopsy. Treatment of hemangioma, surgical excision indicated in symptomatic hemangioma, that means when pain or hemorrhage is there, or whenever there is diagnostic uncertainty. There is one more benign condition called as the focal nodular hyperplasia. It is rare. It is a benign condition. Cause not known. Pathology: focal overgrowth of functioning liver tissue supported by fibrous tissue. So there will be multiple nodules of the liver. That is because of overgrowth of normal liver tissue. It is not pre-malignant. Clinically, it affects middle-aged females, and this also is incidentally discovered. Investigations: ultrasound scan will show a hypoechoic mass in the liver. CT scan will show hypervascular lesion with central scarring. Then you have to do FNAC or true-cut biopsy that will confirm the diagnosis. So the normal hepatocytes and normal Kupffer cells are seen without any pleomorphism or without any feature of malignancy. Treatments: no treatment is required for this particular condition. So why you have to know all these benign conditions? Because most of these conditions, they are incidentally discovered. So whenever you see a solid mass in the liver, so we will be under the impression that probably it may be malignant. So it may be malignant, that is true, but apart from malignancy, there are certain benign lesions also are present in the liver, which can give a hypoechoic mass on ultrasound scan or CT scan. So whenever you do CT scan for a hypoechoic mass, you should do the contrast enhanced study also. If it is a slow contrast enhancement, then you must consider it as hemangioma and don't go for biopsy. For all other lesions, where there is contrast enhancement or no contrast enhancement, you do the true-cut biopsy under guidance. That will confirm whether it is malignancy or not. If it is malignancy, then you have to do the other investigations to stage the disease and plan the treatment. Already we have discussed the planning of the treatment. So this completes the topic on the disease of the liver. So please tell me if you have any doubts. I will clear those doubts, and then congenital diseases, and then the other diseases of the bile duct apart from the stones. Suguri operation. So devascularization operation means yes, I will answer first the question whether these masses in the liver affect the function of the liver. Are there any symptoms? Usually these benign masses, they do not produce any symptoms. Symptoms are produced occasionally. That is because of rupture and hemorrhage. Or sometimes there may be stretching pain in the right hypochondric region. Otherwise, most of them are found incidentally on doing ultrasound scanning or CT scanning for some other condition. So they are mostly 99% of them are asymptomatic. The hemorrhage occurs only for adenomas, hepatic adenomas, apart from hepatocellular carcinoma. So whenever there is spontaneous hemorrhage from the liver, then we have to suspect hepatocellular carcinoma and of course also adenoma. So that is the answer for the first question. The second doubt is devascularization operation. Okay, I will show the slide and then I will explain it. Devascularization operation is done for what condition? What are the indications for devascularization operation? Varices. When do you do devascularization operation? What are the indications? It is mostly done for acute varicose bleeding. Next, it is done for those cases where you want to prevent the recurrent bleeding when EST and banding are not successful in eradicating the varices. Now we can see here the part of the stomach which bleeds or part of the gastrointestinal which bleeds is the lower end of the esophagus and upper end of the stomach. So what you do is the paragastric and paraesophageal veins which are there on the sides, they are cut and ligated. So you can see the short gastric vessels are ligated on the fundal side. On the lesser curvature side, all the vessels that supply the lesser curvature are cut and ligated. The coronary artery and coronary vein. So the coronary vein is ligated here. So in this patient, there are two coronary veins. That's why two coronary veins are ligated. So the venous drainage from the portal vein into the stomach, because there is reversal of flow, is prevented to this area. But the gastroepiploic vein is left intact. That is why the blood can flow into the gastroepiploic vein and then it can go into the stomach. In the stomach mucosa, the blood vessels are also dilated. So they will go and communicate with the esophageal veins, and the esophageal veins again may get recurrence of the varices. So what you do is at the lower end of the esophagus, you do transection and do re-anastomosis of the esophagus. So whenever you cut esophagus and suture it, in the suture, all the submucosal veins will be ligated automatically. So there will be circular suturing will be done. So with the circular suturing with the stapler, the all the veins will be completely ligated. So this is called the devascularization operation or Siguria operation. And of course, this is also clubbed with splenectomy. So spleen is removed, the short gastric veins are ligated, the veins at the lesser curvature and paraesophageal veins, they are ligated, coronary vein is ligated. So the veins and the greater curvature below the fundus of the stomach are left intact. So all the other veins are completely ligated on the borders of the stomach. So this leads to devascularization. And you club it with splenectomy plus esophageal transection followed by anastomosis with the help of a stapler. So by this method, we are stopping the inflow into the varices. So the varices gets the blood from these sources. That's why you are cutting all these sources. That's why the veins collapse and bleeding will stop. Is it clear? Is this clear or do you have still any doubts in this devascularization? Shruti, is it okay? Okay, are you able to hear me now? I can see what you have typed now. Acha. Yes, we anastomose, we do the resection. The stapler means actually what we do is, so actually stapler anastomosis means you will pass, the stapler is passed through the anterior wall of the stomach. You can see a opening is made in the anterior wall of the stomach. The stapler is passed inside the stomach into the esophagogastric junction. It has a head and the body. So what you do is there will be a screw at this end. If you loosen the screw, this will go up. A groove will be felt through the esophageal wall. What you do is you apply a ligature, a tight ligature in the screw. Then you approximate the head to this body by tightening. Once it gets totally approximated, then what you do is you fire the gun. Once you fire the gun, a sleeve of tissue is cut with two rows of staples made all around it. That means it is as if esophagus is cut and again sutured. So esophagus is cut and again anastomosis to the stomach. So the continuity of the gut is maintained. But because there is a row of staples all around, the vascular flow from the stomach to the esophagus will be stopped. Hope I am clear. There is no limit. There is no segment of esophagus is cut. Just it is cut and sutured. just above the stomach. You don't resect 2 or 3 centimeters of esophagus. What you do is you just make an incision and then anastomose it. All this is done with the help of the stapler. The intention is not to remove the area bearing the varices. The intention of transection is to cut the flow of blood from the stomach towards the esophagus through submucosal veins. It is only a dam to block the flow. It is not to cut away the varices bearing esophagus. It is not like that. Intention is not to cut the varices bearing esophagus. Is it clear? Achha, probably you are under the impression that the esophagus, varices bearing esophagus will be transected. That may be in your mind. No, that is not correct. The intention of doing the transection anastomosis with the help of the stapler is to block the flow of blood through submucosal veins from stomach into the esophagus. This is a retrograde flow. So it is retrograde flow. That's why the retrograde flow is stopped. Now the blood flow from the esophagus will be now towards esophagus veins. They go upwards towards esophagus veins. Okay. Are there any doubts? If there are any doubts, I will clear them and then I will go to the bile ducts remnant topics. Okay, shall I go to the bile duct topic? If you have no more doubts, I will go. Okay, that's fine. So the miscellaneous diseases of the bile ducts. So there are certain diseases. We will just finish them off. Extrahepatic biliary atresia. There are a lot of interruptions today. Sorry for that. So this is some problem with the internet or the software problem. I don't know. Okay. This is extrahepatic biliary atresia. So there will be atresia or non-development of the bile ducts outside the liver. This occurs 1 in 14,000 live births. Sex, males and females are affected equally. Pathology. The cause is unknown. The extrahepatic bile ducts are progressively destroyed by an inflammatory process and they are replaced by fibrous tissue at the time of birth or just before birth. Because there is biliary atresia, there will be stages of bile in the ducts and that will lead to secondary biliary cirrhosis, which later leads to portal hypertension. The untreated child dies before age of 3 years due to liver failure or hemorrhage. Types of biliary atresia. Type 1, atresia of the common bile duct. The common bile duct is just like a fibrous band. Type 2, atresia of the common hepatic duct. That means the bile duct as common bile duct, common hepatic duct, and gallbladder, they become atretic. Type 3, atresia of the right and left hepatic ducts also. The right duct and left duct also are atretic. So there will be proximal biliary dilatation. I hope I am audible and you are hearing. Okay. Because there was interruption many times, so I was just make sure. I want to make sure that all of you are hearing me. Clinical features are features of cholestatic jaundice from birth or first week of life. There is jaundice, pale stools and dark urine, steatorrhea, which can lead to rickets in the child. There will be pruritus. Clubbing and skin xanthomas occur. Hepatomegaly with or without palpable gallbladder. Gallbladder is palpable in type 1 cases. In type 2 and type 3, gallbladder is not palpable. So the features are just cholestatic jaundice at birth or in the first week of life. Differential diagnosis. So if any newborn child is having jaundice, we have to differentiate the child from these conditions also, like choledochal cyst, inspissated bile syndrome, antitrypsin deficiency, cholestasis associated with intravenous feeding, neonatal hepatitis. So these are all the conditions which you have to differentiate. So these are all the pediatric problems. So we are not going to discuss how we are going to differentiate these various conditions. Investigations, biochemical investigations for confirming upset to jaundice. Tell me what investigations you do, biochemical investigations. So when the child comes to you with deep jaundice, pruritus, clay stools, on an examination there is hepatomegaly, gallbladder is palpable or not palpable. So tell me, in that child, what investigations you do? Serum bilirubin, very good, alkaline phosphatase. Conjugated, unconjugated bilirubin. What about SGOT, SGPT? You do it or not? Yes, you do them also. So SGOT, SGPT. Then you assess the liver function status. How do you assess liver function status? Hope you are now seeing my video as well as you are hearing. I think I said it right. Please let me know. Okay. Okay, we will go ahead with the class. The differential diagnosis is colorectal cyst. So whenever a child comes to you with a newborn child presents to you with obstructive jaundice features, we will do biochemical investigations. Then we will do the ultrasound examination. So ultrasound examination will show the dilated bile ducts. As we cannot do ERCP, we will do the radionuclide scan to visualize the site of obstruction. So the differential diagnosis is colorectal cyst, insufficient bile syndrome, antitrypsin deficiency, cholecystitis associated with intravenous feeding, neonatal hepatitis. Then liver biopsy is done in delayed cases to know about the biliary cirrhosis. Treatment type 1, hepaticojejunostomy, RU-NY method. This RU-NY method is a wonderful procedure to do anastomosis in various parts of the alimentary tract. So this method all of you should know, because as we go down the various subjects now, that means stomach, the intestines, the colon, the rectum and the anus, we will come across this RU-NY method. So if you know about this RU-NY method, it is okay, well and good, we'll go ahead with the topic. Otherwise, I will discuss something about RU-NY method, how the procedure is performed. So this is for type 1 cases, that means where only CBD is having atresia, common hepatoduct duct is normal, then what we do is we anastomose the dilated common hepatoduct duct with jejunum. That is called hepaticojejunostomy operation. So the common bile duct is having atresia. So the bile duct, common bile duct, sorry, common hepatoduct duct and proximal part of the common bile duct is dilated here. So what you do is you do anastomosis of the common hepatoduct duct with a loop of small bowel. So this loop of small bowel is made by a procedure called RU-NY. So you can see here, this is stomach, this is the duodenum, this is the duodenojejunal junction, and this is the proximal part of the small intestine. Now at this place, the jejunum is cut and this is taken up and anastomosed to the hepatic duct. The continuation of the gut is made by anastomosing the end of the proximal part of the small bowel with the side of this loop. So ultimately this gives the shape of Y. As this was described by Ru, that is why it is called the RU-NY method. Here X is silent. When you pronounce it, this must pronounce it as RU-NY method. How this RU-NY method is performed? This is stomach, this is the duodenum, this is the small bowel. The small bowel is having the blood supply coming from the superior mesenteric artery. The blood comes in the form of arcades in the mesentery. So arcades are nothing but the branches which divide and anastomose to one another again to form arches like this. So there will be at least 2 or 3 arches. These are called arcades. From the last arcade, the single branches will go and they supply to the jejunum. These are the straight vessels. So there are no communicating branches here. So these are the arcades. So now in this procedure, we will take advantage of these arcades. The jejunum is transected 25 centimeters below the duodenojejunal junction. So we have 2 pieces of jejunum here. Then the mesentery is marked. You can see here the mark. The marking is done just below the upper arch. So there are 2 arcades.
So the second arcade is there. Just below the second arcade, you mark the vessels and how far you want to have the length of the jejunum, free jejunum. To make this free jejunum, we cut the mesentery. We cut the mesentery in such a way that the free jejunum has the blood supply. So what we do is we cut the second arch in the middle because it is having communication. So even if one small vessel is here, through that vessel, the second arch will get the blood supply. From the second arch, the blood supply will be given to the bowel. So it is marked like this and it's cut and ligated. So this is the cut end of the jejunum. This is the cut mesentery. Once the mesentery is cut here, you can take the jejunum to any length you want. You can take it to liver, you can take it to the spleen, you can take it to the esophagus, and you can do anastomosis. So now this part of the bowel is taken to the liver and anastomosis to the hepatic duct. And the end of the proximal part which was cut here is anastomosis to the side of this particular loop. So now it has become a Y-shaped anastomosis. So this is called Roux-en-Y hepaticojejunostomy. So this is the duodenum C loop. This is the proximal part of the intestine. This is anastomosis side of the loop. The loop is being taken like this and placed here and anastomosis to the hepatic duct. Is this Roux-en-Y clear for you? Roux-en-Y operation, is it clear? Yes, it is a jejunojejunostomy, end to side, end of the proximal loop, anastomosis to the side of the loop. Yes, you are right. It is end to side jejunojejunostomy. And for this loop, again, the hepatic duct is anastomosis to the side of the jejunum, not to the end, because technically it is easier to make a small hole in the side wall of the jejunum and do the anastomosis with the duct, rather than anastomosing a large diameter end of the jejunum to the bile duct. So usually the bile duct, so the jejunal end is closed, a side opening is made, and the bile duct or hepatic duct is anastomosed to the jejunal loop. Is it clear? Roux-en-Y anastomosis. Other indications for Roux-en-Y, it is being used wherever you want to bypass the gut anywhere. It is used in total gastrectomy. When you remove the stomach, for carcinoma of the stomach, then you take the jejunal loop like this and anastomose it to the esophagus. Similarly, in the next class, we are going to discuss about pancreas. So there is a condition called chronic pancreatitis with multiple strictures of the pancreatic duct. So in that case, there will be longitudinal pancreaticojejunostomy. So in the longitudinal pancreaticojejunostomy also we use the Roux-en-Y loop. So there are many other places where you can take this Roux-en-Y loop and anastomose. Yes, end of the hepatic duct to the side of the jejunum. That is how we anastomose. So type 1 procedure is the hepaticojejunostomy. For type 2 and type 3, where common hepatic duct is atresia, common hepatic duct is having atresia. In type 3, right and left hepatic ducts are having atresia. So there is no proximal part to anastomose. What you do is you do a procedure called Kasai procedure. In the Kasai procedure, what you do is this is the undersurface of the liver, and here is the porta hepatis. The bile duct is a common hepatic duct and right hepatic duct, they are all become fibrotic. You excise all that. You dig into the porta hepatis. That means you go on dissecting the porta hepatis by just cutting the liver tissue there. After dissecting about 1 or 2 centimeters deep, you will find the dilated ducts coming from the liver. The ducts will be seen, 2 or 3. So then you anastomose the Roux-en-Y loop to the dissected area of the porta hepatis. What you do here is radical excision of all bile duct tissue up to the liver capsule is performed. A Roux-en-Y loop of jejunum is anastomosed to the exposed area of liver capsule above the bifurcation of the portal vein. So when you core out liver tissue in the around the porta hepatis, you will find 2 or 3 bile ducts openings. So to this liver capsule, where you have cored out, so to the margins of that, you do the hepatojejunostomy. So you do a Roux-en-Y loop and take it and then do the anastomosis at this place. This is called portoenterostomy. That means to the porta hepatis, you are doing the anastomosis. That is called the portoenterostomy. If the patient is having biliary cirrhosis, then we do liver transplantation. So that is about the biliary atresia. The next condition is the biliary cyst. There are two types of biliary cysts. One is the intrahepatic cyst, the other is the extrahepatic cyst. Intrahepatic cyst is called the Carolus disease, we have discussed in the previous class. The other one is the extrahepatic cyst that is called the choledochal cyst. So the biliary cysts are classified as intrahepatic and extrahepatic. The intrahepatic is called the Carolus disease, congenital dilatation of the intrahepatic bile ducts. It is a rare congenital non-familial condition. Yes, the liver capsule can hold because there will be fibrosis all around. So the fibrosis will hold the jejunal loop. There is no problem about that. There will be irregular sacral dilatations of intrahepatic ducts separated by segments of normal or stenotic ducts. So you will find the bile ducts are like this. There will be saculations and narrow strictures. So there will be multiple cystic like formations will be there for the ducts. This leads to biliary stasis. Biliary stasis leads to calculi formation and cholangitis. Clinical features: age, childhood or in early adult life. There will be recurrent attacks of cholangitis. Complications: cholangiocarcinoma. Treatment: antibiotics for the cholangitis. Removal of the calculi. If the condition is limited to one lobe of the liver, lobectomy is indicated. If it is bilateral diffuse, if the patient is getting recurrent cholangitis and complications, then he has to go for liver transplantation. Then extrahepatic biliary cyst is called the choledochal cyst. So the liver, so the bile duct is dilated. You can see here it is dilated. This is called the choledochal cyst. It is due to specific weakness in the part or whole of the wall of the common bile duct. These are all various types of choledochal cyst. Type 1 means it is just like a cyst. Type 2 means it is like a diverticulum. Type 3 means terminal end of the bile duct is only dilated. This is called the choledococele. The cyst actually projects into the duodenum and you will see a cystic mass projecting into the duodenum here. Then the fourth type is called as the Carolus disease, which we have just now discussed. So there will be extrahepatic bile duct dilatation, that is choledococele, plus intrahepatic bile duct dilatation, that is Carolus disease. If both are there, then we call it as type 4. Type 5 is only the intrahepatic bile ducts are dilated. That means only Caroli's disease here. So there are 5 types of colorectal cysts. Clinical features, it may present at any age, usually it occurs during puberty. There will be attacks of obstructive jaundice with cholangitis. In some patients, a swelling may be detected in the upper abdomen. Investigations, biochemical investigations to know about the obstructive jaundice. Then we do the ultrasound scan. If ultrasound scan shows dilated bile ducts, then we can go for MRI scan. The MRI scan will show the definite extent of the lesion. ERCP. So this is ultrasound scan which shows a cyst-like mass in the hepatic region just below the liver. When you do ERCP, you can see this dilated bile duct here. Sometimes it is so much dilated, it looks something like a big spherical mass. So in such cases, there will be palpable mass in the right hypochondric region. Management, excision of the cyst followed by hepaticojejunostomy. Whenever hepatic jejunostomy word is used means it is hepatic jejunostomy with a Roux-en-Y loop. It is an ideal procedure because you are removing the cyst wall also. Cyst wall, if it is left like that, after about 20 or 30 years, it can develop cholangiocarcinoma. Cystojejunostomy, that means anastomosing the cyst to the jejunum. The problem here in this case is colorectal cyst. There will be dilatation with lack of emptying of the bile, leading to stasis. So we want to relieve that stasis. So if you excise it and do hepatic jejunostomy, that is ideal. Or else you can do cystojejunostomy. That means anastomose the cyst to the jejunum. This is usually not done for fear of cholangiocarcinoma because cyst wall, if it is left like that, it can undergo malignant transformation and can get cholangiocarcinoma. Cystoduodenostomy, that means anastomosing the colorectal cyst to the duodenum. In this case, cholangitis and stromal stenosis is very high. So the ideal procedure is excision of the cyst with hepaticojejunostomy. So remove the cyst and do the hepaticojejunostomy. So this is one of the cases. A girl aged about 12 years. She was brought to me with the features of obstructive jaundice. Then biochemical investigations were done. The patient proved to be having obstructive jaundice. Then the second step of investigation, the ultrasound scan was done. There is dilated bile duct. Then ERCP was done and that has shown a spherical cystic mass in the bile duct. The film which I have shown just now, ERCP film. So that was the film of this patient. So then I plan to do the the cystectomy. So the colorectal cyst along with gallbladder, cystic duct up to the common hepatocyte duct was isolated and it is excised and afterwards is removed followed by hepaticojejunostomy. So the next topic is trauma to the biliary tract. Bile ducts are very much enclosed. So they are covered in front by the liver. They are covered behind by the kidneys, inferior vena cava, below by gut, above by the liver. So whenever there is trauma to the bile duct means you should always suspect that there is injury to the important organs all around. There can be liver injury, there can be kidney injury, there can be inferior vena cava, aorta injury, like that. So trauma to the biliary tract, if it occurs due to assault, will be usually fatal. But the commonest cause of trauma to the biliary tract is due to operative procedures like cholecystectomy. So when you are doing cholecystectomy, there is always the danger of injury to the bile ducts. Okay, so there is no doubt here. How do we differentiate between colorectal cyst and cholangiocarcinoma? Clinically, we cannot make a differentiation. We had to do ultrasound scan followed by ERCP or MRCP. In the ultrasound scan, you will see a large dilated bile duct, like a spherical one. That is the colorectal cyst. Cholangiocarcinoma, proximal biliary duct dilatation will be there with a mass in the bile duct. ERCP or MRCP will definitely show the nature of the enlargement as well as if growth is there, the growth can be discovered on MRCP or ERCP. So the differentiation between colorectal cyst and cholangiocarcinoma is only by imaging studies, not by clinical means. Okay, trauma to the bile duct cause operative trauma is the commonest cause. The other cause is penetrating wound or a crush injury. It is a rare cause and usually it will be fatal. Effects of injury to the bile duct. If the injury involves whole thickness of the wall, there will be leak, biliary leak. If the injury involves partial thickness of the wall, only part of the wall is damaged. Full thickness is not involved, only partial thickness of the wall is involved. So then there will not be any leak immediately. But patient may manifest with late presentation of biliary leak on 5th to 7th days due to sloughing and separation of the injured duct. The duct which is injured partially, it gets sloughed off and full leak will develop. So that leak will develop on 5th day or 7th day. Immediately the patient is okay. For example, the surgeon has done cholecystectomy operation. If he has cut the duct means immediately during surgery itself he will see bile leaking out from the bile duct. If he has if the surgeon has injured only partial thickness of the wall of the bile duct, then there is no bile leak. The surgeon feels that everything is okay. He sutures the abdomen or he takes away the ports and closes the ports if he had done laparoscopic operation. On third day to seventh day, anywhere, then the patient will come to you with bile peritonitis. If a drain is there, there will be leakage of bile through the drain. If drain is not kept, means the patient will come to you with severe pain abdomen and fever due to peritonitis. Sometimes partial thickness is there where only very superficial layers have been injured. The deeper part of the duct is preserved. I am talking about thickness. So outer layers of the bile duct thickness only are injured. Then what happens? That injured part will heal by fibrosis and that leads to a stricture formation. So injury to the bile duct can manifest as immediate biliary leak or delayed biliary leak on 5th day or 7th day or as stricture of the bile duct. So these are the three types of manifestations of injury to the bile duct due to trauma, due to operative trauma. So clinical features, it depends upon whether the injury is detected in the immediate postoperative period or later. Immediate postoperative presentation, profuse and persistent leakage of bile from the drainage tube or bile peritonitis if drainage is not provided. Late presentation, when the injury is partial or minimal, there will be progressive obstructive jaundice. That means due to stricture. So their stricture will develop that produces a progressive obstructive jaundice. Treatment: if the gallbladder is injured, the treatment is cholecystectomy. Bile duct injury treatment: T-tube drainage into the bile duct and drain to the site of the damage. That means when a bile duct is just damaged, just only partial cut is there, then just like what you have what you have done the choledochole operation, there also you have cut the bile duct. Similar way, there is a injury to the bile duct. So there, how did you close it? You just put a tear tube and then close it. Similarly, here also, whenever there is a partial injury of the bile duct, then what you do is you insert the teeth tube and leave the teeth tube outside. Keep a drainage at the site of the operation, so that if any leak is there, that liquid fluid will come outside. So bile duct injury detected at the time of operation, teeth tube drainage. Detected late, on third day or fifth day or seventh day, there is leak of bile. Then what should you do? Many of them will stricture, and this can be repaired by roux-en-y anastomosis at a later date. So stricture of the bile duct. Stricture can be to the common bile duct. Strictures can be to the common hepatic duct. Strictures can be to the right hepatic duct. So this is the biliary ducts. When you are doing cholecystectomy operation, the injury can happen to here, to here, or to this part. So the left duct is usually not affected. Classification of strictures: benign and malignant. Benign strictures, 80% of them are due to operative strictures. That means following trauma to the bile duct during surgery. 20% are due to inflammatory conditions. Then malignant strictures, that means cholangiocarcinoma. Of course, this is the classification of the strictures. This is not necessary for you. Type 1 means low common hepatic duct stricture. Type 2 means mid common hepatic duct stricture. Type 3 means high common hepatic duct stricture. 4 means the stricture at the confluence of the common right and left ducts. 5 means there is a rare anomaly of sectorial branch. So when the sectorial branch of the common hepatic duct is involved, then it's called type 5. So these are not necessary. The stricture is a result of injury to the bile ducts, a preventable error in the operating technique of cholecystectomy. So whenever you are doing cholecystectomy, you must always be careful about the bile ducts. So how the bile ducts can be injured during cholecystectomy? What are the causes? Blind plunge application of a hemostat to a bleeding cystic or accessory cystic artery or to the right hepatic artery. For example, you are doing cholecystectomy operation. Suddenly there is a gush of blood. So whenever there is bleeding, actually you will become panic. So under that panic condition, if you just put a artery forceps to clamp a bleeding site, so there may be injury to the bile duct here. There may be injury to the right hepatic duct, or there may be injury to the cystic duct. So any of these things will be injured if you just push a hemostat into the pool of blood and try to occlude the bleeding point. So that's why blind plunging of artery forceps into the depth of a wound where there's pooling of blood should always be prevented. So prevention is by Pringel's maneuver. What is Pringel's maneuver? We have already discussed. In hepatic trauma, we talked about Pringel's maneuver. What is that? This is again a short notes question, frequently asked in the examination. What is Pringle's maneuver? Yes, clamping the blood vessels and bile duct in the foramen of Winslow. Yes, very good. That means obstructing the inflow into the liver. This is the foramen of Winslow. This is the free border of the lesser momentum having the portal triad structures here. Now we are doing surgery for the gallbladder. In the callus triangle, when you are dissecting, accidentally some vessel got injured and there is profuse bleeding. So how are you going to manage? So that is our question now. So this is the free border of lesser momentum. This is the hepatic artery. This is the right hepatic artery. This is the cystic artery. So here is the foramen of Winslow. Just behind this is the foramen of Winslow. So there is sudden gush of blood. So the surgeon and his team goes into panic. So you want to stop the bleeding. So immediately if you push a clamp and then clamp it, you can clamp any of these structures. You can clamp the hepatic artery, you can clamp the common bile duct, you can clamp the right hepatic duct or right hepatic artery even. So if any of these things are clamped, they will pose lots of problem. Sometimes it can even lead to death of the patient. So what you do is you pass your index finger through the foramen of Winslow. So when the finger is passed, the finger passes behind the portal triad structures. You can see here. Then you place your thumb in front of it and occlude it. So now between your thumb and index finger, the free border of the lesser momentum is being pinched. It is being pinched. Then you put a sucker there, suction apparatus tube, and with the suction cannula, you aspirate all the blood. Because your finger has occluded this and you keep the occlusion like that, how much time you can keep the occlusion like that? Tell me. How much time you can occlude the vessels in the porta hepatis? This is called the warm ischemic time. So what is the warm ischemic time of the liver? Yes, it is the 45 minutes. So you can keep the vessels clamped for 45 minutes. So when you want to do repair, you can take your fingers and you can put a occlusion clamp, arterial clamp. So there are special clamps are there. They are called DeBakey clamps. So you put the DeBakey clamp and then occlude the vessels. That means for so long time to keep your fingers pressed over the structures will be difficult and your fingers will come in your way to repair the blood vessels there in the porta hepatis. So once you find the lesion, then what you do is you get a vascular clamp and put it in the foramen of Winslow and occlude it. Then the bleeding will stop. Then you can do the repair. Yes, if you are doing a laparoscopic surgery, immediately you must convert it into a open surgery. If the bleeder is seen and if the bleeder can be managed with laparoscopy, you can continue with the laparoscopic surgery. If the bleeding is profuse, where you cannot identify the bleeder, the blood is just flowing onto your lens and you are seeing everything dark, then don't wait there for too long to locate the bleeder. So best thing will be to open the abdomen as quickly as possible and do the Pringle's maneuver and suck the blood and find the bleeder point and repair it. So once you find the bleeder point, now you can see here there is a small tear in the right hepatic artery. So right hepatic artery can be now sutured here. The where the tear is there, that tear can be sutured with 6-0-proline. The prevention of this tragic happening is standardized by Pringle's maneuver. So remember this, this is a very life-saving and important procedure in hepatic surgery. All unexpected hemorrhage in this region should be controlled initially by inserting an index finger into the foramen of Winslow and pinching the free edge of the gastrohepatic momentum between the finger and the thumb. Temporary compression of the hepatic artery in this way allows the bleeding point to be visualized and ligated or repaired securely. The second cause of injury to the common bile duct. Tenting of the common bile duct by too much traction applied to the freed gallbladder in fundus first method and ligating the angulated CBD for the cystic duct. I will explain this. In doing cholecystectomy, there are two methods. One is a retrograde method, the other is the antegrade method. Retrograde method means this is also called the duct first method, where you start your surgery at the callus triangle by dissecting the duct, ligating the duct, and proceeding towards the fundus of the gallbladder. This is the commonly done procedure. But some surgeons, what they do is they start from the fundus of the gallbladder. First, dissect the fundus of the gallbladder, separate the gallbladder from the gallbladder fossa of the liver, then you ligate the duct and remove it. So this is called the fundus first method. So when you do fundus first method, there is every danger of this particular injury to the common bile duct. This common gallbladder is very much freed. So you hold with the clamp, and while you are doing surgery, you put traction. So when you put traction, this becomes something like Y. So you consider this part as the cystic duct and put a ligature here. Then the bile duct will be ligated. So you must be very careful whenever you are doing fundus first method. So that is why, because of this danger, fundus first method is not advocated. So the commonly advocated procedure is the retrograde method or duct first method. Duct first method. So the anatomy should be identified before ligature by relieving the traction and confirm the junction, and then put the ligature only to the cystic duct. The third cause is failure to identify the anatomy in callus triangle. When there is a lot of fibrosis, the cystic duct sometimes will be found completely adherent to the common hepatic duct. So then you may think that this is the cystic duct and put a ligature around the common bile duct. When there is inflammation, the common hepatic duct may be mistaken for and ligated instead of cystic duct. Fourth is ignorance of anatomical anomalies of the bile ducts. Sometimes we have studied various anomalies are there. So sometimes there may be anomalies. So in these anomalies are present, you may mistake the one of the branches of the hepatic duct to cystic duct, and you may put a ligature over that. Laceration of the common bile duct while exploring it for the stones. Then injury to the common bile duct during unrelated surgical procedures like gastrectomy or Whipple's operation. So whenever the duct is injured, there will be fibrosis. Sometimes the injury may be only to the right or left hepatic duct, and that will produce the stricture of that particular duct. When only one branch is involved, that lobe, that particular lobe, becomes atrophic because of secondary biliary cirrhosis. and also from poor portal venous flow or due to bile stasis. And the other lobe, there will be compensatory hyperplasia. The patient manifests with progressive cholestatic jaundice and its sequelae. Investigations, the same investigations, ultrasonography, ERCP, if not possible, percutaneous transhepatic cholangiography or intraoperative cholangiography. So this is an example of ERCP showing stricture along with leak. Treatment, immediate treatment in the debilitated patient, temporary biliary drainage. That means you provide biliary drainage either by passing ERCP and then you pass a stent. If it is not possible, you do percutaneous transhepatic cholangiography and over that you put a tube. That is called percutaneous transhepatic biliary drainage. I think you are following these words, PTBD, stenting, you are following, I suppose. Already we discussed these things. Definite treatment is for a stricture of the recent onset, you do ERCP and balloon dilatation with insertion of a stent. For a benign stricture or duct transection, you do Roux-en-Y choledochojejunostomy. So the stricture is there to the bile duct where you can't put dilators and you can't put a stent. Then what you do is you do hepaticojejunostomy. You cut the duct there, anastomosis to the Roux-en-Y loop. For this operative photograph. Next is the biliary fistula, and there are some more conditions like carcinoma of the gallbladder, cholangiocarcinoma, and parasitic infection of the bile duct. So that will take another 40 or 45 minutes. So we will do it in the next class. So with this, we are going to complete the topic on the liver. So the next topic will be on pancreas. Do you want pancreas or stomach? Hepatobiliary and pancreatic will be, I think, will be good. So I think pancreas will be ideal. So tomorrow we will go ahead with the disease of the pancreas, that is acute pancreatitis, chronic pancreatitis. Then afterwards we will discuss about the pancreatic tumors, endocrine and exocrine tumors. Then we will discuss about this biliary fistula and other things. Okay. Now we have some doubts from our students. The first one is ERCP. Shruti, what type of ERCP image you want? Do you want normal ERCP or ERCP in specific some disease? Acha, acha. In the film, what I have shown here. Okay, we will show. I will show it. This is the ERCP film. This is the bile duct. You are seeing bile duct. This is right hepatic duct. This is left hepatic duct. This is the common hepatic duct. It got injured here during laparoscopic cholecystectomy operation. You can see the clips, images of the clips here. So this got injured here. So ERCP was done. So this is the cannula that is sent into the bile duct and dye is injected. Now the dye has gone like this and it has gone into the bile duct, but you find a narrowed portion here and much of the dye what you have injected is just leaking out here. This is all the leaking dye. So this dye is leaking onto the left side and collecting here. Is going to the right side like this. So what you are seeing, all this is the dye which is leaking. That means there is a tear followed by stricture. That means there is stricture with a opening. So this is the place of the stricture. Okay, because so many white shadows are here, you are getting confused. You are not able to understand where the stricture is there. This is the place of the stricture. If you go to the ERCP room and then see 2 or 3 cases, then definitely you will get a better idea of the bile duct imaging. Okay. In acute bile leak after teeth tube, what should we do? In acute bile leak, you put a teeth tube and drain it. Close the abdomen. 3 weeks later, you do a teeth tube cholangiography. That means inject the contrast into the teeth tube and take the image of the bile duct, whether it is completely normal, whether the duct is uh, dye is flowing. Yes, it is okay. Good. Bile duct is normal and dye is flowing freely into the duodenum. Then what you do is you hold the tube that has come out from the abdomen and pull it. You pull it with a sharp pull. The teeth tube will come away. For 3 weeks, you kept the tube there like that. So within 3 weeks, what will happen is around the tube there will be some fibrosis. So a track will form from the bile duct to the skin. So though you remove the tube, the bile will not leak into the peritoneal cavity. The bile will flow through the tract outside. So for 2 or 3 days, there will be leakage of bile, but much of the bile will go through the normal passage. Small part will come through the opening made for the teeth tube. After 2 or 3 days, that gets collapses and that closes. That is how you manage the teeth tube. Yes, this healing usually will not produce stricture if there is no circumferential injury of the bile duct. If there is only injury to just only one part of the bile duct, this won't produce injury. It won't produce stricture. But if there is some circumferential injury, some part is crushed, then definitely it will produce stricture. So in such case, the best thing will be to do a hepatojejunostomy. If a small linear tear is there, then you can go with teeth tube. But if there is circumferential tear, so it is not ideal to go with teeth tube. Better to go for hepatojejunostomy, or you have to keep a stent. The stent should be kept for about 6 months to 1 year. If a small linear tear is there, if you remove the teeth tube, afterwards only that linear part gets healed. It is not, if it is not circumferential, there will not be any stricture. Is it clear? Next class will be tomorrow. And we'll put the notice for that on the website in an hour or so. So after 6:30 or after 7 o'clock, you please see, then you will see the message on the website and you will get the email to your email ID. So next class will be on pancreas. That is tomorrow at 4 p.m. Any more doubts? Okay, thank you very much. Wish you all good night. See you tomorrow at 4 p.m.